I'm a Baptist preacher, and when I see this many people, I really feel like I need to give a sermon. So I hope that I'll take a collection. Maybe I should take the collection first. I want to first of all thank the Interfaith Center for having this event. It is tremendously important, and it has been an eye-opener for me, and I know for the members of CTAC. And I know as John started this conversation, you saw the word CTAC, and I know some of you thought that it was the airport in Seattle or some military acronym. But it is the Coalition to Transform Advanced Care. And 3 years ago, when I became a part of it, one of the first questions I said to myself is, how in the world could these folk have the audacity to create a coalition to transform advanced care? Particularly when very few people knew what advanced care was. But we've done it. And I want to invite Brad and Quay to come up. And the reason why I'm inviting them to come up with my presentation is that we at the Interfaith and Diversity Working Group use the understanding of Ubuntu as our center piece for really dealing with this issue. And Ubuntu in South Africa, and in the South African tradition, says, I am because we are, and we are because I am. And that is the relationship that we have developed, not only with CTAC, but we're developing across the country to deal with those issues. Could you please come up? There are 2 chairs up here for you. 3 years ago, there was a moment when people across this nation came together, unlikely people, to join together to deal with this issue of advanced care. And John talked about the over 100 groups that have come together to deal with this issue. But also out of the spirit of coming together, there was a spiritual moment when individuals from churches, synagogues, mosques, and people from the Baha'i faith and from the Buddhist and Hindu tradition also came together, and also people who were non-spiritual came together and created the Interfaith and Diversity Working Group. And that working group saw as its mission to be the bridge between the various other working groups in CTAC, saying that the centerfold for CTAC had to be spirituality. And CTAC adopted that, and so when you see the diagram of CTAC, you'll see the spokes in the middle of the wheel as the Interfaith and Spirituality Working Group and Diversity Working Group. One of the things I wanted to do was to have this opportunity because I wanted to just talk to you a little bit about your concerns, a little bit about your struggles, and a little bit about what you see as a way that you can involve yourselves in this movement that is going across the country, that is creating a new paradigm for how we deal with advanced care, and also a movement that's redefining the whole issue of what it means to be a patient by looking at the whole issue of people-centered care and not patient-centered care. So let me first of all raise 2 questions with myself, and Brad and Quay are going to answer those even though they don't know that yet. Brad, I'm struggling with how do doctors financially, how does doctors and clinicians financially benefit from advanced care? And secondly, how does the pharmaceutical companies, how do they play into this process, and what do they get out of it? And what does the hospitals get out of it? Everywhere we've gone, they've said that, you know, when you come in, we will save on the other end by cutting down on our emergency rooms. Therefore, we will be making more money than we made before, while at the same time we will be providing a service. And I'd like them to respond to that, and then we're going to talk a little bit about the model, and then Bob, I'm going to shut up because I still might raise that collection. Quay, would you start?
You should introduce yourself, or I should, so people know who you are.
Well, would you?
Yeah, Quay Nguyen is has a doctorate in pharmacy and has done a lot of work with medical groups in California to establish the kinds of care that we're going to be talking about here. I met her when she came to Sutter Health, where I had worked for 18 years or so, to start this sort of care up, and Quay just really took hold of it and organized it so that we could roll it out across the whole 24 hospital system, and it went very well in all kinds of ways, not least of which was that the hospitals and the doctors all learned that we could do care differently. And but a lot of it was through creating a system that benefited everyone. So I think maybe that's the way to start to answer the question, and then I'll defer to Quay, who's used to answering tough questions.
Well, actually, I'm not at all, and thank you, Brad. I'm with centuries of wisdom here in this room, so I am in search of answers, just as all of you are, and very blessed to be here. And I think, if anything, I think the work that we've done inside the healthcare system may have been just the blessing that I have of just approaching it from pure innocence and using humanity as a way of going forward. So going back to Tyrone's question, how does this benefit the healthcare system? The kind of care that we're talking about, the kind of care that we need inside the delivery system and outside, in our communities, in our places of worship, doesn't really make business sense in the current healthcare structure. The current healthcare structure actually incentivizes clinicians to do more, to treat, to provide as many procedures as we can possibly do, to give as many treatments as we could possibly do. So what we're talking about here is coming together to really change big systems, and it's going to take our humanity to do that. And so the kind of care model that we propose inside CTAC requires all of us working together to change into a new business model, a business model where it makes sense to really care, where it incentivizes all of us, the physicians, the nurses, to really look at the person and really care rather than to give treatment, to give procedures. And so I think that is a big task ahead. And healthcare and the structure and the system needs as much healing as we all do. And so this is going to take a movement, and it's going to take all of us.
Can I weigh in on this? I think, I mean, I agree with all this, but I think actually this model is already in play.
Right.
And the fact that the government payment systems have not gotten aligned with it yet doesn't mean that nobody has. I mean, Sutter certainly has been doing it for years. And I think I heard Bill Frist, former Senator Frist, physician, talk the other day, and he's founded a company, a palliative care company. Now, if Bill Frist didn't think he could make money out of this, he wouldn't be doing it. But the fact is that patient person, thank you, centeredness, and good business in hospitals are not antithetical. In fact, done correctly, they are synergistic. And that's what people need to understand. This is not an opposition where if you do patient-centered care, you're going to lose money. It's not necessarily true. If you do it badly, you will lose money. If you do a spiritual assessment as a physician, you save time in your practice. You don't add time to your practice. Christina Pahalski at George Washington has demonstrated that very clearly across the country. If you teach medical students to reflect on their own spirituality, you reduce physician burnout, increase their effectiveness. So this is all now in literature, and it's not just crazy people who are out like me and you, and others who are out there saying it. I think it's true, and we just passed a bill in Congress, the Impact Bill. The Institute of Medicine came out this week with a report on dying in America, which talks about all of this stuff, and I'd recommend that to all of you if you can. You don't have to. You can read the summary, not all 507 pages. But I think this is coming, and I think we can be encouraged.
Brad, do you want to add something?
Sure. I think there's a new era that it's not just coming; it's already arrived. It's a little slower to arrive in some places than others, and we're sitting in one of those places where it's taken a while. That doesn't mean it won't come, but I think there's a big controversy that we always toss back and forth inside our little circle here about cost. Costs money. This has come up a little bit today. We haven't really gotten into it, and there are those among us who say we really shouldn't be talking about the cost of care and saving money, because the second you say we're going to save money by providing a different kind of care, what's thought is going to be in many people's minds. You're making money on the backs of the sickest people we have, and you're going to be denying them care and all that. I think a better way to think about it is the new era that's coming is that doctors, we health system people, whether we're doctors or hospitals, are going to just wind up being paid in a different way than we are now. Right now we're being paid by the piece. So if I remember when I used to be on call all night every day of the week, and when I got a call at 3 a.m., and it sometimes was my third trip to the hospital at night, I said to myself, if I didn't get paid for this drive and staying up for 2 more hours and not seeing my kids when they get up in the morning, I don't know if I could do this. And if I did procedures in my office, I got paid for each one. So when people say you're incentivized to do more, what they mean is, if what you sell in your shop is procedures, you're going to see if you can do good business. So that's why everyone now is starting to move toward a new system where you're no longer going to be paid by the piece, you're going to be paid to take care of a group of people. We would refer to that as population, but population is kind of a cold term. It's you have a group of your fellow human beings that you care for, and you're paid on a regular basis for that whole group. And so all of a sudden you have to start thinking, well, wait a second, if I get paid to take care of this group and the pay doesn't change, then I have to start thinking about what I can do to provide the best care I can, and everything else is extra. As that system comes into play and the gear teeth start to mesh, what happens, and we know this in California because we have managed care out there since the 80s, and we still do. What happens is doctors start looking at each other, if you're in the same group, and start saying, we got to start thinking about how to provide the right care, not just the most care. And what it really does is it's not so much talking about reducing the cost of care, although that's what happens. It's that you put the care of the people that you went into this business to care for, you put the care and the finances on the same side of the table, and you have to think about both. And if you're putting your kids through college, taking care of your parents, you got to make a living. So you care about that, and you also care about your patients. but you have to care about them together. You're not thinking about, all right, how can I get money from somewhere else for doing more? You're thinking about, how can I be responsible? How can I be a steward of the resources so that the community benefits as well as just my own patients? And that's where we're moving. So in that new way of putting finances and caring on the same side of the table, a new kind of care makes much more sense. So Tyrone will be talking more about that, but briefly, it's we now get to begin to care about people so that if they don't want to, they don't even have to become patients. And that's a radical change for those of us who have been trained to look at a sick person and think, patient, see you in the hospital. You know, there are many different ways to handle it once you realize that it's a person and they have a life, and they may want to live that life as long as they can and not see you until they absolutely have to. So that's the new world that's coming.
Yeah, and let me just say this. I know we don't have a lot of time, and I won't talk about the Oakland model in depth, but one of the things that's happening is that there is a movement, and the movement is really a movement of you. It is a movement of people from diverse backgrounds, from diverse cultures, from diverse interfaith traditions, that is now taking ownership of what happens in your community and what happens in the health programs and plans that are a part of your community. Oakland and Alameda County is an example of that, where a community has come together and they have determined that caregiving and the support of caregiving is their primary foci. And what they have done is they have developed partnerships with members of foundations and the health community and health plans to really begin to say, look, this is what care looks like from my own tradition and culture, and this is what we're going to do to transform, ultimately, the healthcare system. That is happening, and it's happening across the country in various pockets. So what we're saying is that now is your moment. Your moment as individuals who are in this room to begin to rethink what your needs are and to rethink what could happen in your community so that you can transform the various health plans and groups in your community. And we'll have more discussion, but I want to ask you, what do I have in my hand?
Blank piece of paper.
A blank piece of paper. So, what is that? It's a blank piece of paper. It needs something to be written on. And right now, as you move into your groups and as you discuss this issue for the rest of this moment and the rest of this day, and hopefully for the rest of your lives, you will be writing and filling out your own agenda and developing your own strategies to transform this nation and this country and the health systems to really meet the needs of your communities. Take your blank piece of paper and fill it out. You have the power to change the course of advanced care in this nation if you would take ownership of this blank piece of paper.
So we're going to take questions, but I also would like to add, if any of you need help filling out that blank piece of paper, if any of you want to join CTAC, if any of you want to join us in this work, please speak to John, Tyrone, myself, and we'd be happy to help you fill out that blank piece of paper. But